Good morning, respected colleagues, respected chairperson. It is a privilege to be here talking with distinguished group of professionals who wants to change the life of people living with diabetes. Today I am not going to talk something which is not very new to you, and it is not something a cutting edge technology or something which is a very new medication, but it is a far more human issue which we often miss in our clinical practice. It is the mental health, the missing piece in diabetes care. We treat diabetes, we look at the HbA1c, we often prescribe the insulin dose, but how often we ask how you are coping with the medication, with your day-to-day living, how this diabetes treatment is affecting you emotionally. Because we know the stress, the distress can make a big change in not only the quality of life of people, but also the glycemic parameters via hormonal influence. We know the science that people living with diabetes are 2 to 3 times having a higher risk of developing depression or diabetes distress and several other mental issues. If you look at the IDF data globally, about 77% of people with diabetes report to have anxiety, depression, and other mental issues. And the top stressors are fear of complications. Many times, if we don't explore, patient बताते नहीं कि वो क्या सोचते हैं कि भाई अगर अभी डायबिटीज है तो हमको बाद में मेरा किडनी का इशू होगा और many other complications which are there in their mind from the day they are diagnosed. Daily management also becomes a burden because we may be looking at the guidelines but may not be addressing their fear and how they daily manage it. If I tell you the evidence-based medicine, the David Sackett model, which is known as the father of evidence-based medicine, what he says that it is not only the evidence for the best medication, it is also the patient acceptance and his quality of life which should be addressed by your treatment, which is also becomes a very important aspect. So daily management is very important for the people's day-to-day living. And also once they are labeled with diabetes, be it type 1 or type 2, it is a stigma and discrimination and fear of needles, which should be addressed. Just we jump on कि भाई आपका A1C बहुत हाई है, अभी आप नहीं लेंगे इंसुलिन तो कुछ नहीं होगा आपका लिवर किडनी. These fear tactics make their life more worse, and actually they don't accept it in this regard. So only also if you look at Indian data, we have people very high number of suffering from depression, anxiety, and diabetes distress. The number is there, but there are many more issues if you look at, and we never address them. So we keep mind and body separately. We look at the parameters which are there in the chart, the level of HbA1c or the creatinine or whatever, but we never address the mental issue of it. So the whole purpose of this talk is to sensitize you to look at whole human, as a whole human, the mind and the brain together. If you look at, there is a bi-directional relation between diabetes and mental health. Stress and day-to-day management, fluctuations in the glycemic parameters, and more importantly, it is our role. We create tension with patient if we are not very careful or very vigilant, that our two words can make the whole day once they come to us and we discuss the issue. आप अच्छे से अपना खाना पीना नहीं कर रहे हैं, आपने एक्सरसाइज नहीं किया है प्रॉपरली, आपका ये गड़बड़ है, वो गड़बड़ है. These kind of discussion may not have a very fruitful effect, and altogether it leads to something called mental burden or mental health related issues. Along with, if at all these issues are there, they may be reflecting in their appetite and change in diet pattern. People have gone even to the level of suicidal thoughts just because it was not, no, they are not taken, the part of mental health was not taken. Nervousness, anxiety, these all we need to be very sensitive to pick up in early. If people are coming with bad control or people are coming with anxiety, sometimes this anxiety will reflect in a way of quarreling with you. It's even हमसे ही आके झगड़ना शुरू कर देते हैं, डॉक्टर साहब आपने ये मेडिसिन दिया, इससे कुछ फायदा नहीं हो रहा है, ये नहीं हो रहा है, वो नहीं हो रहा है. एंड व्हाट वी डू इन रिटर्न, वी ट्राई टू increase it further. Actually, these are hints which gives you that he is suffering from some or other medical stress or medical condition, and he is in distress rather. And these things leads to what? All hormonal stressors like cortisol, norepinephrine, serotonin levels, which shoots up. So these all contribute to the diabetes, poor diabetes control. If you look at the data, the diabetes is associated, you look at the relative risk of different psychological diagnosis which is there, mental disorder, depression, insomnia, anxiety, eating disorder, even schizophrenia and bipolar disorders, post-traumatic stress disorders, everything, if you look at the diabetes, they are having 2 to 3 times higher risk. So we do see there is the clear-cut link here. And if you look at the prolonged stress, how it is going to affect, just we are talking, it's not only the hypercortisolism or other hormonal mechanism, even with effect of a stress, some people will come कि बहुत tension से sugar बढ़ गया है. Actually, the tension which is there, they change the lifestyle. They are not able to adopt the healthy behavior. Rather, all the negative aspect of health goes much higher, and they may have unhealthy nutrition or exercise and other related issues. So this is how the dual combination of hormonal and lifestyle changes, both are directly influenced by the mental health issue. So we do have these other mechanism, either by inflammation. So maybe insulin resistance it goes up to. If you look at overall activation of sympathetic overactivity, nervous overactivity at the level of hepatocytes. So look at the effect of having mental stress or psychiatric disorder at glycemic parameter of a person. So what are the key critical points? If you look at these people, if you want to, now you think, yes, I have to look at these people very carefully. You should be picking up the negative social perception of people. No, they may come and they talk to you in a different way. And even the distress which we create to them. We should be very vigilant to this. It's distress with family and friend. Sometimes there is maybe a loss of family, or maybe a dispute between family members, or even husband, wife. Even the adolescent have a lot of other issues. So we may be able to sometimes help them with our just bringing up these issues in the discussion. People, once they have suffered hypoglycemia, they do have a distress. Now, and this goes to, say, days together. They may suffer for some few minutes, but the distress goes for days together, and we need to be very vigilant in this matter also. And also related to drug or management issues, we may be giving them medication several times, and insulin and other things which may not be very easy for them to accept or to take care of it, how we prescribe. So again, I'll talk about evidence-based medicine as by David Sackett. We may not be a very, the evidence which suggests that you should be doing this, but we should always discuss with the patient, take their consent and their desire that how medication they want. See, a person who may need insulin, you know, very urgently. It may not be acute condition I'm talking about in OPD basis. And you jump to right because you get all those data in favoring of having insulin in the treatment. But the patient may get depressed and you have to take time, you have to make them understand. So there are issues, these are 7 critical issues which has to be there, and eating distress is one which we should be always, we do see every patient suffer from powerlessness and negative thoughts which we have discussed. So what are the factors which contribute to mental health issues? Either type 1 and type 2. It is patient related, it is family and friend related, but I want to sensitize you about it is us which we also create these stress. So we should be very, very again be sensitized about these issues. So these are the precipitating factor which can trigger mental health issue, like change in life, particularly people with type 1 from childhood to adolescent. If you look at the data in European or Western world, the girl child is more prone for it. However, even the male child suffers equally once they change, because they want to explore different things in life, and the diabetes and insulin becomes a hindrance to it. So this is the time when you have to be very careful, and they should be given extra time to address this. Again, the marriage, the pregnancy, the menopause, each change in life can trigger these factors. So you should be very vigilant. Again, change in diabetes status, change in healthcare, like even changing physician. So you may be referring to somewhere else, or even they do change sometimes. So these all can trigger them having mental issues or mental health related. Just data suggests, if you have even asked for the investigation, they are very scared. बोलते हैं क्या निकलेगा रिपोर्ट में, क्या आ जाएगा, कहीं मेरा किडनी गड़बड़ ना हो गया हो, कहीं मेरा, these all issues which we, for us it may be very simple that we think it is nothing, but then it can be a big mental health issue for people living with diabetes. Sometime again I talked about the pharmacological and non-pharmacological therapy, maybe an insulin therapy or even a drug, even an expensive drug. They will be thinking so many other points related to this. कैसे हम इसको पूरी जिंदगी खाएंगे, क्या होगा, and they try to, they have so many aspects in their mind. So these all issues has to be taken care. So how do we, these are again major sources of mental health in type 1. We have discussed powerlessness, negative social perception, physician distress, family and friend distress, hypoglycemia. We have discussed all the 7 major issues we discussed. Screening is again the most important part of discussion today. Once we have been, we are looking at now very carefully कि कोई हमारे पास आता है, so we may be able to pick up that he is having some mental health issue, or maybe he is depressed, or maybe a diabetes distress. So once we have detected, how do we exactly quantify it? So there are different screening tools which are very sensitive, 80 to 90% sensitive and 70 to 85% specific. And if you look at diabetes specific screening tool, there is a problem area in diabetes. There are different 20 questionnaire I'll discuss, and diabetes distress scale is there. If you want to look at the quality of life index for people living with diabetes, we have WHO 5 well-being index, and also depression and anxiety. We have patient health questionnaire 9 depression score. If a score is higher, more than 10, you can calculate. These scores are available online, which the questionnaire can be downloaded. Generalized anxiety disorder, 7 scores. So you have different scores which are validated, quite validated. If you can give it to your clinical staff or somebody who you feel that he need to be screened properly, you suspect, then you need to get this. If you look at problem area in diabetes, they have 20 different questionnaire related to their feelings, emotions, sleeping pattern, anxiety, feeling of different aspect of their social or mental issues. You can download and you can calculate them. There are scales for adolescents separately, children and short person. I'm not going to go in detail in each questionnaire, but it's very easy to get it on web. And we also have diabetes distress scale where having 17 different questionnaire, similar kind which you can always discuss. So these are a very specific screening tool, and we may need it in several of our people if you suspect them to have. So what are basic core symptoms if you want to pick up? Suppose you are very vigilant now. Sense of inability to cope with the prescription like diet, exercise. If somebody is not very comfortable, he is feeling that it is very difficult for me, the medication, the investigation, you have to again screen them. Fear of developing complications, as I discussed. Worry about health outcome, dissatisfaction with social support. भाई घर में हमको हेल्प नहीं मिल रहा है और मेरा ड्यूटी जॉब फ्रेंड्स फैमिली anywhere you can find out there will be one or two things which you can always pick and you can help them with that. So this is the management plan for such mental health issues. We may not be a psychiatrist, but there are cases which we can help, and we can also take help of people if you feel that the scores are very high. Like, we should be aware that people with diabetes may experience diabetes distress or other psychiatric illness. So we should ask them. We never ask. That's what I started with my presentation. We may look at the A1C number. We may look at other parameters, but we forget to ask them how you are feeling with your diabetes control. Are you feeling overwhelmed with the medications? These all different questionnaires which can help them to identify them, assess them for diabetes distress and with a validated questionnaire which we discussed. Then we need to advise them. If at all you think you need another professional help, you should go, because people may have a very severe degree of issues which may need specialized help, because they may get several other issues related to it, or you also can help and then again reassess them and arrange for the next appointment. Sometime we can ask them to come separately for this issue when you are comfortable to discuss, when you have the sufficient time to discuss. You can ask them to come on for the following subsequent visit, and you can address these issues. There are different way of managing, different aspect of managing diabetic people, other than guidance on self-care. Cognitive behavior therapy is very effective, and we all do it somewhere, sometime, but we need to be we should be learning about cognitive behavior therapy, lifestyle modification therapy. These are all some soft skill that we need to have in our practice. And also we should be having psychological drugs which are required when you find that patient need antidepressant or antipsychotic and anxiolytic. So I'll be focusing on cognitive behavior therapy more so because these can identify negative thoughts in patient. Cognitive behavior therapy helps challenge these unhelpful beliefs and replace them with the realistic, empowering thoughts. Goal setting is also becomes very easy, like when you talk, like आपको इतने देर टहलना है, 10 मिनट वीक में 4 दिन 5 दिन भी टहल लें, and then you see that you can improve it. So these things can help a lot and go long way in helping people with diabetes. Behavior activation also is very important. You go step by step in helping them. Last visit to Baroda, I talked about lifestyle modification, different aspect of it. So there are certain challenges which are related to diabetes, society related, psychogenic related, which I have discussed, but very important. Marriage is an important factor in where we can look at them in their issues. I just wanted to show you this down to study about diabetes attitude, wishes and needs study, which is a very elegant study of 15,000 individuals. I will not go because it was in a pan, 17 different countries were involved, which were not only patient but also healthcare, nurses and family member. And they could see that there was a high emotional distress in people. There are unmet psychological needs for several of these people, gap in communication, cultural and systematic barriers are there. So there are measures to overcome. Again, this is a very exhaustive euthymia model where we talk people with empathic communication. We try to listen to their issues and we try to speak them to improve their self-efficacy and self-awareness. And there are motivational interviewing to these people which can make big change in glycemic parameter. Not only the quality of life index, but also the glycemic parameter. You can get down the levels with your just a motivational talk, these people, and find ask, tell, ask technique. There are several other methods which we can learn about these things. So there are studies to cope mental health issues by routinely addressing the diabetes distress in our practice, acknowledge emotional response, and other related methods. How do we do this? Just a small snapshot. We can initiate dialogue about distress, identify them, we recap, normalize, acknowledge them. These three things which I discussed, ask, tell, ask method, can help a lot in planning and helping them. This is the flow chart where we detect mild, moderate, and severe symptoms, and we can arrange them, separate discussion on it, or we can also refer them to different. Even our RSSDI has given an exhaustive specific intervention for such people living with diabetes, especially for children, adolescent, youth. It is by our Dr. Brijmohan Makkar and team, which we have done. In guideline also they have included. So we should be going in detail about it and finding different aspects of it. There are national and international guideline also to say what I have discussed in a similar way about emotional and health related aspect of it. So lastly, I want to just say that we should be treating mind and body together. Let's be more vigilant and see each people, they need to be discussed on these issues and help them in long run to make their life more easy and more happy. Thank you. Thank you a lot.